Tony, there was an interesting CDC paper about Guillain-Barré syndrome. So there was a safety signal after Shingrix. They did the review. The good news for every million people vaccinated, you had somewhere between 43 and 65,000 reduction in the cases of Zoster, its complication, but you had an increase between 3 and 6 cases per Guillain-Barré syndrome per million people vaccinated. It was a little bit confusing because that was implying that it was actually one above the other, but they were largely saying we should be greatly reassured. But people do freak about Guillain-Barré ever since swine flu and influenza back in the 1970s. Could you comment on the interpretation of that CDC paper?
Yeah, I did mention that, and it's really, they compared the first 42 days after second dose and after each dose, sorry, not just the second dose. And it was indeed about 3 per million, which is very similar to adenovirus and influenza vaccines, but not RNA vaccines, as I understand. And of course, Guillain-Barré can occur after viral infections such as CMV. It is a rare complication of these vaccines.
But they didn't specifically put the background rate. So for a lot of us who are trying to explain it to people is that there is a background rate regardless, and they're going to find that, but Absolutely. They didn't necessarily equate it to that.
Absolutely. We don't know all the causes of Guillain-Barré, but we do know that it can be associated with specific viral infections, as I mentioned, and flu vaccine, which is extremely well known.
Yeah, Michael, I think you wanted to tackle some of the online questions. Thank you.
I don't want to tread on Tony's toes, but the answer to your question, yes, sorry, yeah, hello, audience. The answer to your question, audience, was I think you can still give the second dose of Shingrix up to a year later. Is that right, Tony?
So 2 to 6 months is recommended, but when they had trouble in the USA with supply, they went out to a year, and it's in fact the immunogenicity would support that.
So that explains why it's a slow rollout in Australia, because no one's worried about doing it in 12 months.
That's another point. And although it's recommended to wait 5 years after Zostavax to get it on the NIP, it's probably better to give it 1 year later, because as we heard from Tony, Zostavax is pretty well useless after 3 years.
Yeah, I think that's exactly right. It's not useless, but it drops down to 35, 40% efficacy. And I think the other thing to remember with Zoster itself is Betty Lou's studies, as well as others, show that recurrent Zoster is much commoner than we thought, probably up to about 10% at 10 years, and it starts increasing after a year. And that's one of the reasons why the Canadians, the US, and ourselves have said that you can actually use Shingrix a year after Zostavax.
But they'd have to pay for it, because it wouldn't be on the NIP until 5 years.
Well, yeah, so that, and I was going to throw that to Katie to say some of the decisions about when the next vaccine, I would guess, and some of the other questions we're getting is about why we're waiting 12 months after an infection, why we're waiting 12 months after or 5 years after. And I would throw that to you with perhaps the suggestion that that might be an economic decision rather than a biological, all that sort of stuff. So do you want to answer that? Thanks, Katie.
Yeah, I mean, I think the economic, it's working. Yeah, I think the economic impact plays into this. I mean, as I showed in the economic evaluations that have been done, there was a question earlier about whether we should be vaccinating younger, and other countries have concluded that that actually is beneficial. And I think just when you see how long this vaccine immunity is lasting, this may adjust in time, but some of these recommendations I think are under constant review at the moment, and this is the initial phase of the introduction of the program last November, a very expensive program that obviously got through the second time the PBAC had the application. So I think that it's good for people to do advocacy around what they think should change and should happen, because I think that there may be changes in the coming years as this program is evaluated. I haven't seen the full economic evaluation of the current program for Australia, but obviously I've shown you some of the economic evaluations that have been done.
So Tony, a specific question about stopping methotrexate and other maybe JAK inhibitors, and then Michael, maybe
the JAK inhibitors are far more predisposing to Zoster than any other DMARD. And the JAK inhibitors would be the ones that I'll be focusing on rather than methotrexate. In terms of the trials for Shingrix in JAK inhibitors will be coming out soon. There are 2 immunogenicity studies, one of which I reviewed recently, so that will be available fairly soon.
And there's 2 questions. One is that it stops the protection from the vaccine, but the person's almost is more vulnerable. Aren't they the 2 issues with? Yeah.
The 2 issues are that they're far more vulnerable with JAK inhibitors than any other DMARD, like 5 times more.
But it also dampens the response to your vaccine?
Slightly.
Yeah, and methotrexate, I think the same sort of question. You're stopping it because you're assuming there's no...
Methotrexate doesn't actually rival JAK inhibitors in this setting.
Okay.
But you wouldn't stop them before vaccination?
No.
Yeah, so that was the question around, do you stop them or change them? Yeah, thank you.
Just to let you know, Targi as well has just gone through a thorough review of the immunocompromised chapter and has been looking at all the different disease modifying drugs and trying to get a much better handle on what the recommendations should be vaccination wise, because it's a very active space, and that chapter update will be coming out in the not too distant future.
There are 4 phase 3 trials in progress at present, so that will influence all of that.
So Michael, to your question about we should all have vaccines again and again and again, or different ones, should we, does that in your mind make an argument to have this at 50 rather than at 65, without talking about the economics, but maybe the dementia?
Well, as Tony showed, the risk of Zoster goes up from 50. Also, the risk of RSV goes up from about 50 to 60. So I don't know that we want to wait until 70 or 75. I'm very disappointed that currently pneumococcal vaccination is recommended at such a late age. What's reassuring is the long duration. For instance, Tony's intimated that Shingrix is probably active for at least 10 years. And so we don't have to worry at this stage about a booster. But yeah, I wouldn't wait until a person becomes old and frail to be vaccinated. And in fact, that might also reduce the immunogenicity of the vaccination.
Just to add to that, the 11-year figures will be out, so probably presented within the next couple of months, and then you'll be able to model. But I did show the immunogenicity plateauing at 10 years, so I'd say 15 at the very least.
So Betty, you got mentioned in the passing. Did you want to ask a question? Thank you.
Yeah, thanks.
From the floor.
Sorry, so it's actually not so much about the recurrence, but just around following up from Tony Corman's question about the dementia and these off-target effects. I guess one of the critiques of some of that evidence is obviously that it is observational and that there is, healthy vaccinee effects that are often quite hard to take into consideration. But I sort of, and I agree that the Welsh study is, methodologically quite strong. But I sort of wondered around having some of these off-target effects as sort of secondary outcomes from trials, and whether there's any thoughts. I don't know, whether any of the panel members might want to comment on that. That that in designing the trials, some of these other secondary outcomes, should be considered, because obviously that that's a sort of strength of evidence that is more likely to convince regulators.
So I think Katie start and then go for it.
I'm actually delighted that we're talking about off-target effects of vaccination. I've been working on this for years and looking at the immunology, and in fact published a paper with a group last year saying that this is something we might want to consider in the future. Now, being on a target, I think I can see we have a lot of components to consider when we're looking at vaccine policy. But I think that it would be great if more vaccine trialists did look at some of these off-target effects, and they are becoming more and more compelling. And it isn't just observational studies. In fact, there's quite a lot of randomized controlled trials of BCG vaccination, very, very clearly showing an almost 50% reduction in neonatal mortality if you give BCG to a low birth weight neonate that wouldn't normally get it. So the data are getting stronger and stronger, and the mechanisms are coming through now. So we've got innate trained immunity, which is an epigenetic effect generally, but other parts of the innate immune system can be trained by vaccines, and that can last years and also can be transmitted to future generations. So this is a huge topic that has taken a very, very long time to take off, and there's been a lot of skepticism globally that vaccines can affect your morbidity, but also mortality, because unfortunately, some of them actually increase diseases and increase mortality as well. So I think it's a really interesting question, and it'll be interesting to see if in the future we start to take these into account when we're thinking about the impact of vaccines. But it's just amazing. Most of the ones you look at, you're seeing these profound off-target effects, which are mostly sex differential as well. So females or males differentially affected.
I think we're entering a golden era of vaccine immunity. Studies I've just looked at recently are looking at effects in tissue. You need to look at lymph node to understand what's happening in induction. You need to look at effector organs such as lung to look at what's happening with resident memory T cells. Multiomics is making a difference. There will be enormous changes, I think, in the future, not just trained innate immunity, but everything, every aspect of immune response.
So we've got another question online, but
Just
Michael
very
first.
quickly though, but I think that these endpoints, these secondary endpoints need to be structured in from the beginning and not a retrospective or an ad hoc analysis. Because for instance, dementia, unless you're actually sure they didn't have dementia at baseline by doing a sufficient cognitive assessment, you could never be sure that it's incident or whether it's just an exacerbation or attenuation of what was previously there. So you've got to structure these in from the very beginning. And some of these outcomes are long-term, 7, 8, 9, 10 years. So the study needs to be sufficiently long to have adequate follow-up.
So in about 5 minutes, we'll have lunch, and remember there's coffee out there on the right if you really want coffee. But Margie, yeah, thank you.
Thanks, Rod. Margie Danchin, MCRI. It's a comment and a question, actually to you, Rod, because I really just want to make a comment about acceptability and coverage, which was the question Katie was asked as well. So we do know flu vaccine is around sort of maybe 40 to 60% coverage in adults. It's lower in kids. And I think with such a good vaccine now with Shingrix, primary care really needs to be on the front foot in terms of advising and informing the public about the reactogenicity of Shingrix for dose 1 and dose 2 in terms of, you know, the local pain and the swelling and the redness, but also the systemic effects. I've certainly had lots of conversations with grandparents over the summer period about this. And I think once they understand it, they expect it, they're happy to come back for the second dose. And I think we really need to make sure that that is front of mind with this program, because it's an extraordinary vaccine in comparison to Zostavax. And we had to overcome this with Bexsero as well for children with the high fever and, you know, prophylactic Panadol with that program, which we don't do for other childhood vaccines routinely. So it's really just a comment, I think, that we need to really push it.
I think it's appreciate it's almost, thank you for asking, because in the last week, we've had national discussions around availability. We've also had a discussion around do we have enough vaccines? It's an extraordinarily high uptake from a primary care practitioner. We're not surprised. And in talking to some of the panel members before this meeting, an educated and literate provider infrastructure, the message gets very quickly to patients that this is a good vaccine. Providers are comfortable in being an advocate, and the sales from our point of view are as we would expect because it's a good vaccine. And we did some work, the Immunisation Coalition did some work about when the high dose flu vaccines were out, when some of the private vaccines were being brought into Australia for flu. GPs told us if there was a 5%, maybe 10% better vaccine on the private market as opposed to the National Immunisation Program, GPs wouldn't invest time to try to sell it. But if there was a 30% or more, so if they perceived, the providers thought there was a better vaccine, they would stop and say, look, there is a vaccine that we think you should consider. So that we just thought that was an interesting thing, is that there kind of is a signal where providers say, look, we think this is better. We're not surprised as frontline people that this has been taken up, because I think we believe it's a good vaccine and we're comfortable talking about it. And the fact there's any side effects really isn't an issue. I think, as we know, if a person who's giving the vaccine says, I recommend it, it's a very powerful uptake. And for people younger than 65. Any comments, Tony? Or...
No, I completely agree, but John Litt might want to make some comments about just seeing we've done a little bit on this in the past.
So any other comment?
It is an issue.
Can we have it for John? Thanks. Can we have it?
practices have got large numbers and have worked out it's going to take them something like 2 years to vaccinate their population and cannot get supply. We're reassured by the manufacturer that there is no issue of supply, that they have provided all of the doses of Shingrix to the Commonwealth as being required. We need a better coordination between each of the state vaccination centres and a clearer perspective about when GPs are actually offering good cold chain, regular clinics, that they ought to get a priority to get the number of doses so they can get the vaccination delivered.
Just I got a question over here, Jim. Yeah.
Thanks, Hugh. Just a quick comment to underline the importance of the education and discussion with patients. So based on primary care data, when it was only in the private market, about 1 in 6 patients don't come back for the second dose. That's based on Victorian and New South Wales primary care data. So the importance of
1 in 6 don't come back. Yeah.
1 in 6 don't come back.
Yeah. So 5 out of 6 do come back. Yeah. So it sounds. Yeah. Yeah. So that's good. So next, sorry. Yep.
Yeah, Ken
Not
Griffin
good, it's not
from
good. We're likely to be much less than that.
Ken Griffin from the
Yes, sir.
Australian Primary Healthcare Nurses Association. It's probably worthwhile thinking about how we're thinking about primary healthcare in this discussion. So if you think about nurses and the significant role they play in vaccination in Australia, but we tend to think primary healthcare and we think general practice almost exclusively. There's 13,500 nurses in general practice, but there's almost 100,000 nurses in primary healthcare. Now, the biggest chunk of them are actually, it's 46,000 of them judging, well, based on the 2022 health department data, they're all in aged care, which for what we're talking about here, it's a pretty prime population, albeit some are above the 80 years, which we know sort of for effectiveness of the vaccine can be an issue. But if we were to think about how we run vaccination in aged care, which has traditionally been done in a really pretty haphazard manner because of the nature of funding in that sector, we could actually get a lot of at-risk people. Any researchers out there?
So
You've got very good medical histories of people who are in aged care, so they've done a lot of work.
To reassure you, I didn't say general practice. I said providers' confidence in a vaccine. So I think that's important. I think Tony might want to talk about the fact that it's still, this one's still effective over 80. So we haven't had that same barrier that the Zoster had, where it just wasn't cost effective above a certain level. So I think there is a recognition here, and I specifically, and the Immunisation Coalition specifically talks about vaccine providers and the support for them. So
And I think particularly for that second dose, that's a good one.
Yeah, just to say that I think it is important to look at the uptake of, or the, should I say, the safety issues of co-administration of vaccines, and particularly now with the adjuvanted flu vaccine is yet to be determined.
So I've got Alan here, but there was also a question about correlative protection. So should we do a lymph node biopsy to see if there's any correlative protection, or can we do a blood test? So to you, Tony, after Alan's question, because we're towards the end of our time and the coffee and lunch are waiting. So Alan, yeah.
But first, just in passing, Michael, intriguing talk, great sales for vaccine, and I hope that can continue. But I want to address the question of that Tony raised just in passing, and which John lit upon, like, should I say, and that's the spectre of Guillain-Barré. And as Tony has said, it happens at a frequency similar over a number of vaccines, including the Shingrix. And I looked at this many, many years ago, and I can't quote any chapter and verse, but as Tony mentioned, there is a background level of Guillain-Barré, and it seems that certain things can actually provoke the outcome or provoke the incidence. And there was a study, I believe, at the early stages when the swine influenza vaccination program highlighted this problem, which showed in subsequent years, I believe, a reduction in Guillain-Barré amongst the population who'd received the swine influenza vaccine. And I think there's a theory that in the background there's this background of maybe susceptible people who at some stage are going to acquire Guillain-Barré under some sort of provocation. And the vaccines are just one of the provocations. And if the vaccine isn't a provocation, then something else will be the provocation at some time down the future. So I think that the spectre of Guillain-Barré is a bad one for vaccines. but it really needs to be put into context that it is simply highlighting that there are susceptibles out there, and at some stage they're likely to acquire Guillain-Barré.
So thank you, and conscious of the fact that lunch is waiting, Tony, any simple?
No, I just think we actually contemplated amongst our autoimmunity and vaccine group looking at this. And the problem is it's just so rare, 3 per million. It would be useful if we had a genetic marker, but I don't know of any.
Some of the big data people might be mining that. So we're sort of out of time, but if you have a quick answer, it's got to be.
I mean, just to comment, people like Jim can know more about this than me. But for instance, for influenza, although there may be a very small increase in risk of Guillain-Barré following influenza vaccination, the risk following influenza disease is about 14 times the risk. So certainly for influenza vaccines, the risk is much higher with the disease than with the vaccine.
So
Jim will nod his head.
Yeah, nodding furiously down the back there. So thank you very much. Thank you to everyone for participation online as well.